welcome all the faculty members and delegates here for a very important webinar on adolescent sexuality issues. For this, I invite Dr. Gujral now to say few words to the audience. Dr. Gujral does not need any introduction. Ma'am is a chairperson in the Institute of Obstetrics and Gynaecology, Sir Gangaram Hospital. Ma'am was past President NARCHI, past Vice President AOGD, and National Vice President NARCHI. At present, Ma'am is a President Society of Fetal Medicine Delhi chapter. Ma'am has written many papers in national and international journals, and Ma'am has written many chapters in the reputed books. Ma'am was awarded a Satyapal Award in 2017 for excellence in high-risk pregnancy management and Medgate 10th MT India Healthcare Award in 2020 for most promising doctor in the obstetric and gynecology. Ma'am, I would request you to say words for our August gathering. Thank you.
Okay, good evening, everybody, and thank you, Chandra. Let me just begin by congratulating Dr. Chandra and her team for organizing this webinar on sexuality issues in adolescent. It's really an untouched topic mostly. So what exactly is sexuality? It is not about being a male or female. It is not about just having an act of sex. It is a complex idea which involves physical makeup of an adult, of an adolescent, how an adolescent feels about herself or himself, how she feels about others, and the society she lives in. For a vast majority of adolescents, at least in our country, sexuality remains a myth, an enigma. Adolescents are curious, their hormones are hitting hard, they want to know all. So if we do not discuss at home with our children, where will they go to? Where will an adolescent go to? Go to the peer group, internet, social media, books, etc. So many factors would affect sexuality of adolescents. Most importantly, being a parenting style, how we bring up our children into adolescence, how we are going to talk to them, how do we gain their confidence in us, cultural relationship, cultural taboos, gender identity, sexual orientation, and above all, her own personality, what kind of a person she is. So what an adolescent should be concerned about is that it is natural for you to ask about sexuality. It is natural for you to learn about it, to be curious. It is also natural for you to have an intimate relationship, whether it is emotional or even physical. But at this young age, you must know the consequences of physical, involvement for yourself and your partner. You should be told, it has to come to you. You cannot be doing without it. Just take it slowly, get reliable information, consult good people, and delay the sex physical once you're sure that you're ready for it, so that this experience, your sexuality, is a healthy, positive attitude, effect on your life, not a guilt for lifetime. And you can take this and grow up, into your adulthood. Now, the program has been very beautifully designed in the form of lectures, panel discussions, addressing most of these issues. I wish the audience, they give some time for the audience. And if some are hearing, the adolescents are there, younger ones, they may be asking questions. I don't know whether you have the non-doctors in the, audience or not. So these issues are going to discuss, and all I can say, we grandmothers and all mothers are going to learn a lot from this webinar about sexuality in adolescents. With these few words, I ask you to start the process.
Thank you, ma'am. You really describe why this topic is important for us to know, all our obstetrician and as well as the other doctors who are looking after the adolescent. So, and all the experts are here to discuss various aspects of this topic. So now for the further proceedings, I invite Dr. Renuka Brijwal to start the first session and then the next session. Dr. Renuka, she's our vibrant associate consultant in our department, and she's going to do the further proceedings of the webinar.
Thank you, ma'am. And a very good evening, to all of you. Now I'm going to start session 1 of today's scientific program. And to chair the session, I would like to invite Dr. Gangadhar Sahu. Sir is a retired professor and had been head of the department VSS Medical College, Sambalpur, Odisha. Currently, he is the president of ISOPARB Society. The mission of and vision of his life is to be a ladder of success for others to climb up. Welcome, sir. Next is Dr. Harsha Khullar ma'am. She is Senior Consultant, Department of Obs and Gynae, Sir Gangaram Hospital, New Delhi. Currently, she is the President, Delhi Gynecological Forum Central. She had been past President, ISOPARB Delhi Chapter, and past Vice President, Narchi Delhi Branch. Welcome, ma'am. Next is Dr. our very own Dr. Professor Mala Srivastava, ma'am. She is Senior Consultant and Professor Gripmer, Sir Gangaram Hospital, New Delhi. Ma'am is past president of AOGD and vice president elect ISOPARB 2023-24. Welcome, ma'am. I request Dr. Gangadhar Sahu to please invite our first speaker, Dr. Latika. Sir?
So your projection slide, please.
Yes, sir.
Thank you, ma'am, for inviting me to be a chairperson on this important session of adolescent sexuality. Really, it is a change in life. Such a change, dramatic change, difficult change that is very difficult to understand. So to start with, let me introduce the learned speaker, Dr. Latika Bhalla, to speak on the health education to an adolescent girl regarding this sexuality. So she is the senior consultant, adolescent pediatrics, Institute of Child Health, Sir Gangaram Hospital, New Delhi. She is diplomat of national boards, diploma in adolescent pediatrics, fellowship in pediatric endocrinology. She had so many awards to her credit. So without wasting much of time, so may I request Dr. Latika Bhalla, madam, to start your topic. Now the podium is yours.
Thank you, sir. Mr. Vinod, please share the slides. Thank you so much, Dr. Chandra ma'am, and then Dr. Gangadhar Sahu, sir. It has been my privilege to present the education regarding the sexuality, which is a very, very important topic for gynecologists and obstetrician, and as well as for the adolescent pediatrician also. So this topic, the main problem with this topic is this topic has never been discussed. So can you make the slide? Sure, yeah. So this topic was never discussed because only thing we were doing as an adolescent pediatrician is like giving an anticipatory guidance to the adolescent children. So it is said in our adolescent department that whenever you have a child who's a 10-year or 11-year-old child who has come to you, maybe for the viral fever or something else, you should take all the history. You should take all the history and see whether he has come just for the viral fever or there's something underlying which is troubling him and he's been brought to the hospital because for this something else. So because most of the time adolescent children will never share their problems, it is basically for us to know whether they have some underlying problem or they are suffering from something which probably they are not able to share with their parents or maybe the caretakers or maybe parents or maybe the caretakers at school. So that is why it is very, very important. Thanks to ISOPARB for giving us an opportunity. Delhi AHA, Central AHA, Delhi IP, all are part of this CME because we have speakers from Gurgaon, Dr. Sunita Manchanda, she is the adolescent pediatrician at Max Hospital. Dr. Swati Ghate, she has her own institute at Jaipur. And Dr. Arti, you know, she's the psychologist at Gangaram Hospital. Dr. Deepa, she's the adolescent pediatrician at Noida. So we have a team which have definitely tried to work on this topic and maybe we are able to do the justice. I will start this topic, why it is important. The next slide, adolescent sexuality, which is the need of the hour. Understanding adolescent, we have to understand, if we have to understand adolescent sexuality, first we have to understand what are the adolescent changes related to sexuality, and what is the normal sexual behavior, sexual experimentation, sexual orientation, and then how to handle changing trends of today's adolescent or teens. Next slide. Sex education is the process of acquiring information and forming attitude, beliefs about sex, sexual identity, relationship, and intimacy. Controversial points are whether the covering sexuality is valuable or detrimental. We have seen use of birth control as condoms and hormonal contraception all have a definite impact on teenage pregnancy and of course, and the transmission of sexually transmitted infection. Next slide. So according to the population, we say we have an adolescent age group which starts from 10 to 18. But in the West or other countries, they take as a young, that is 10 to 24. So if we see the 10 to 24 is 284 million is the total population. And it is a total 30% of population. But if we see as such, we have almost 1.2 billion adolescent children worldwide. And we have in the age group of 10 to 19, we have almost 253 million adolescent children. So which is almost 21 to 22% of total population. And if we see percentage of male enrolled in secondary schools and percentage of female enrolled in secondary schools, there is a wide difference. So average age at first marriage, or you can say at the marriageable, is 20, and total fertility rate is 3.4, and percentage use of contraceptive is only 7. Next slide. Next slide. Yeah. So according to NFH's 5 study, early marriages still stands at the 23.8% across India as per study done by Mehra et al. 29.3% of ever married women aged between 18 to 14 have experienced spousal violence. India has third highest HIV infected population in the world with the nearly 35% of all AIDS cases. Transgender students face physical, verbal, and relational bullying and lack of treatment, low health literacy, and poor healthcare services available. Next slide. So we have an adolescent, which they are adolescent age starts from 10 to 18 or 19. So from 10 to 13, we can say that is early adolescent. And from 14 to 16 is called as a middle adolescent. And from 16 to 18 or 19 is the case called as late adolescent. So if we see, there are different changes which are happening during the adolescent. One is the onset of puberty, which we see starting with the menarche or the change in even the boys. So that is the biological change. And then comes the emergence of advanced cognitive abilities, which is responsible for the cognitive change. Self-image, intimacy, relationship with adults and peers, that is the emotional change. And transition into new roles in society, that is what is called as a social change. Next slide. So if we see, there is 2 studies which I have taken. One is the 2003 British Columbia Adolescent Health Survey, which has been a very huge study. There are almost 289,767 children were included in this. They say that their adolescent who eventually identify as a gay, lesbian, or bisexual will not always do the same during the adolescence. Many young people who engage in some sort of same-sex experience are not gay, and many gay teens have never had sex, and then they turn out to be a normal heterosexual also. And then there is another study which was done by Halpern et al. That they have studied around 11,000 young population. They said that 19% lost virginity before marriage. Early exposure to vaginal sex is responsible for huge risk of sexually transmitted diseases. Next slide. So according to the Sigmund Freud, which is the main psychiatrist who has been studying regarding the psychosocial development, so there are different phases which starts right from the after the neonatal age group: oral phase, anal phase, phallic phase, latency phase, and genital phase. This is as landmark steps of psychosocial development. During the adolescence, an individual enters into genital phase from the latency stage. Next slide. So we have adolescent sexuality, which is the center of cognitive, psychosocial, and cultural, physical changes of puberty. And if we take the center of all, so that is what we will consider as a sexuality. Next slide. So what is basically human sexuality? The sexuality wheel depicts the comprehensiveness of the concept of sexuality. These factors influence our unique personal manifestation of sexuality. Sexuality is more than just a vagina or it is an intercourse. So there could be what are the values, communication, self-image, sex, which is gender, socialization, physical expression, body image, and personality. This is according to the Calgary Health Ridge. Next slide. So what is sex is biologically means a male or female, which is an act meant for reproduction. Gender relates to how you feel inside, whether you feel like a boy or a girl, or socially constructed. There is a difference between the socially constructed characteristics of men and women. How you feel about yourself as a person, how you feel being a man or woman, how you behave with the same or opposite sex, communicating your needs to others and respect for others. So in the gender, we have identity, expression, and biology. And in the sexuality, we have attraction, identity, and behavior. Next slide. So there are 3 stages of adolescence, which I have already discussed. First is 10 to 3, where we have SMR 1 and 2. Secondary sexual career structures are getting formed. Sexual interest, there is a more of a sexual interest during 10 to 13, usually than the asexual activity. And by the time they come to the 14 to 16, they are in the SMR 3 to 5. There is a sexual drive surges, experimentation, questions of the sexual orientation start. And by the late adolescence, we have SMR 5, consolidation of sexual identity. Next slide. Next slide. So these are the physical changes which are specific to next. Just complete the slide. Click again. Yeah. So in the male, we have seen there is an early testicular growth, puberty, testicular penile growth, height velocity changes, and all then the height and muscle changes. Next slide. Keep on clicking. What is sexuality? Keep on clicking. Yeah. So masturbation is touching oneself. That is basically the self-stimulation of genital organ. It is a normal part of growing up. No treatment is required. Both girls and boys, normally they do, but they feel very conscious of that. Then next is wet dreams. During sleep, expulsion of semen because of contraction of muscle. It does not make one tired, sterile, weak, insane, impotency, because there are a lot of myths related to that. Just click again. Yeah, all married, young, unmarried adults, they can do, and first night is not crucial. And these are the old myths which are related to the wet dreams and masturbation. Next slide. So wet dreams will not exhaust anybody's stock, and the size of the phallus does not matter. Next slide. Next slide. So whenever these photographs which has been taken from our government program, so उसमें लिखा गया है, there is a शिक्षक द्वारा दिया ज्ञान, माता पिता की बात और दोस्तों की सलाह. So we have to tell the children that they have to take a proper education from a proper person. So whenever they feel that they should not feel guilty about anything, and then whenever they have some kind of a negative thought, they have to channelize and divert their attention to other pleasurable like studies, hobbies, and games. Next slide. Next. Yeah, keep on continuing. Yeah. So in the females also we have a menarche, and then there is a pubic hair and complete the development, breast part, pubic hair, menarche, axillary hair, and of course then the final pubertal changes in the breast, pubic hair, and completed height. Next slide. Yeah, so they basically for the girls, there could be a sexual attraction. Sexual attraction is a feeling that the sexual people get that causes them to desire sexual contact with a specific person. Squishes is an aromatic crush, a desire for a strong platonic relationship. Romantic attraction is a feeling that causes people to desire a romantic relationship with a specific other person. And sexual attraction is desire to be a sensual but not sexual. And crushes is a romantic attraction to someone, a desire for a romantic relationship of some kind, a desire that is possibly temporary in nature. And aesthetic attraction is an attraction to other people that is not connected to a desire to do anything with them, either sexually or romantically. They simply appreciate their appearance. Next slide. So what kind of a sexual behavior that depends from the country, society, culture, family norms, personal values. So normal range for, we can say in a city like Delhi, there could be sexually explicit conversation with peers, obscenities and jokes with cultural norms, flirting and courtship, or there could be solitary masturbation, hugging, kissing, holding hands, and dating and crushes. Next slide. According to the Mashro, there has been a physiological need, safety needs, love, belonging, self-esteem, and self-actualization. Just click again. For boys and girls, the self-actualization is different. For the girls, they are more attached emotionally as compared to the boys. Next slide. So sexual experimentation can come in form of a masturbation, daydreaming, crushing, reading sexually explicit material, looking at porn magazines, watching porn movies, sexting, sexually explicit video games, and there may be drugs and cocaine also may be part of this. Next slide. So what is sexual orientation? It could be a homosexuality. Homosexuality is romantic attraction, or you can say sexual interaction or sexual behavior between members of the same sex or gender. Next slide. So it could be in the early adolescence, the homosexual phase with boys, they make a gangs and homosexual experimentation could be there. With the girls, there are lesser of that kind of things. And the middle adolescent, there is a more of experimentation and heterosexual phase, and the late adolescence, time to consideration of available adult lifestyles. Next slide. So there is a loss of childhood innocence, lack of emotional maturity to handle these changes, physically capable of doing and enjoying sexual intimacy, but not yet capable of handling the emotional consequence or medical issues related from that. And extreme peer pressure to fit in or to be cool and happy, they may take a wrong kind of a decisions out of that. Next slide. So sexual attraction is always a hallmark of a teenage, and premarital sex is a global phenomena. Sexual relations occur before they acquire skills and they are not expert in self-protection. Next slide. So this is a survey that says around in 2019, the kind of a premarital sex was much less as compared to the 2013. And then how the people expect them to be. So homosexuality is an acceptable sexual preference. Next slide. Basic changes are difficulty in trying to break away from rigid society norms and Indian traditions, and difficulty in acceptance of new terms. Immoral now is a personal choice or lifestyle. A perversion now is a different orientation. Next slide. So how can we help? First, we have to be comfortable with our own sexuality. Then we have to teach the boys and to respect the girls. Life skill education is very important, and POXO Act also should be taught to everyone. Next slide. So this probably will be dealt in the next talk also. But we have to look for red flag sign of a sexual act as a counselor and facilitator to those who approach the doctor. And family dynamics are very important as a backdrop in children, adolescents who engage in premarital physical relationships. Next slide. So if we say according to the Act of Youth Center for Excellence, what is the definition of sexual as? This is what it makes for me to be sexually healthy. I'm comfortable with my body and my sexuality. I'm able to recognize risk and ways to reduce them. I can talk effectively with my peer, family, and partners. I know my body and how it functions. I know how to access and use healthcare services and information, and I'm able to appropriate all the boundaries. I understand the risk, responsibility, and consequence of sexual behavior. Next slide. Thank you.
Thank you, Dr. Latika. It was very eye-opener, and you have beautifully discussed about the adolescent sexuality education, which is a need of the hour, really. Because many of the things we don't know about the adolescents, what are they doing, what is happening in their mind and all. And it was really eye-opening, and I think it's very important that right from the school onwards, they should be told about the sex education and all. Now, coming to the
Thank you, ma'am. Thank you for your kind words. Within 12 minutes, I have tried to, say just few terminologies, because otherwise this topic is too long and too, detailed to be covered in just 12 minutes.
Right, I know, but you're beautifully discussed, and the common problems which I think the adolescents face, I think you have beautifully discussed, because they should know each and everything, that what are the advantages as well as disadvantages and how to cope up with them. And now I think it's very important that we thank you, Dr. Latika, once again. Now we come to the next topic, that is how to assess. Dr. Gangadhar Sau, can you please throw some light on this topic?
Yes. So actually, this is a problem not for the adolescent boys and girls. I think it is more problematic for the parents.
Yes,
They
I
should
totally agree.
yes, because parents and grandparents, they have to play the major role. Just I will take 1 minute.
Sure.
So there is a story that one adolescent girl asked her mother, how I was born? By the grace of God. Mother replied, how you were born? By the grace of God. How your grandmother was born? By the grace of God. Then the girl said, oh ma, for 3 generations there is no sex. I cannot stay in this family. So therefore, our girl or the
This is modernization, sir.
So therefore, we have to very much calculate it to make the girl understand, so that she will have confidence to disclose everything to the parents. So that should be the aim, not that the parts of the body, the sexuality, all these things. But what she needs, that is the actually need of the hour to tell her. Thank you very much, madam.
Thank you, sir. Thank you. Now we move on to the second topic, that how to assess difficult adolescents. I think we are seeing so many girls and boys in schools who are facing this problem. And there is a psychologist also in the schools, because you can take any advice from them. And it has been seen that almost 1/3 of the population belongs to the adolescents. And almost they say that in US there is 92% of the youngsters they are facing the mental illness. And what mental illness? That leads to the suicidal tendencies, depression, going in for the drugs and all. So they become very difficult. And Dr. Deepa, she is going to tell us that how to assess difficult adolescents. Dr. Deepa, she is the senior consultant, Apollo Hospitals, Noida and Delhi. And she is the chief coordinator of SPERS, Child Development and Adolescent Clinic, Apollo Hospital, Noida. And she has got so many achievements and honors, that past president of the IAP Noida placed in the excellent report of the Apollo Hospitals, awarded the academic achievements, so many feathers in her cap. So I think I now invite Dr. Deepa to speak on this, how to assess difficult adolescents. Dr. Deepa, please, are you there? Hello?
Ma'am, you're mute. Thank you, dear Dr. Harsha. It was always a pleasure to be, and it's an honor to be, introduced by you. You have been my teacher, guide, everything, and it's lovely to have all my old friends on this forum. Well, every parent is in a dilemma as to how to deal with their teens, and sometimes it may be very hard to believe, but no. Your teenager is not an alien being from a distant planet, but they're wired differently. You may feel exhausted from lying awake at night, worrying about where your child is, who they are with, and what they are doing. You may despair over failed attempts to communicate, the endless fights, and the open defiance, not to mention the moodiness, the intense emotions, and the impulsive and reckless conduct. Normally, the parents come to the counselor, adolescent pediatrician, to know about the working of the magic wand to help their teens navigate through the troubled waters. With these words, I would like to share the screen and start off with my talk. And there is a very nice tool. Is it okay? Am I? Fine. Is it okay?
Yes, we can see your slide. Yes.
Fine. So adolescence is characterized as everybody has said in the Dr. Latika has beautifully summarized about different concepts in the sexuality. There are other conflicts of values and emotional stress and readiness to extreme attitudes. And this invariably leads to several psychosocial problems of adolescence, problems of health and physical self-esteem, sex and reproductive health problems, home and family related problems. The overall goal of psychosocial history taking is to identify modifiable risk factors and engage in a healthy conversation that empowers the adolescent to reflect on their own lives about the changes that may be able to make. So teens differ from adults in their ability to read and understand emotions in the faces of others. Adults use the prefrontal cortex to read the emotional cues, but teenagers rely on amygdala, the part of the brain responsible for emotional reactions. And teen brain is still developing. The part of the brain that controls how teens react to the situation is the last to develop. The normal for teenagers to make poor choices, and it is on us to let them know that we are there for them and they can make mistakes. And if your teen is doing something that could harm themselves or others, we have to talk to a professional. Characteristics of adolescence: the biological growth and development. Onset of adolescence is marked by the beginning of puberty. Specific hormones are released, growth spurts, voice changes, development of sexual characteristics, complexion problems. Undefined status is some are treated as children, some as adults, allowed to marry at age 16, vote at age 18, and drink at age 21. Some adults like adolescent culture, others are critical of it. So there is increased decision making. More decisions must be made by oneself, increased pressure from the parents, friends, teachers, and this results in different sort of behavior by the adolescents. Peer pressure is the strongest. Many teens feel pressure to be in a relationship or even to find a job. There is search for self. So the ability to establish personal norms and priorities is important. Preparing for future roles is one aspect of finding oneself. Anticipatory socialization is learning the rights, obligations, and expectations of a role to prepare for assuming the role in future. So the adolescents are peer dependent, they're egocentric, have distinct language and dress, they're popular cultural influence, and there is ongoing search for identity. So the policy on confidentiality, that is very important, that when you are counseling an adolescent, you have to have a policy on confidentiality, and it should be assured to them that our discussion will be private, and we hope that you feel to talk openly with us about yourself and your health. Information is not shared with other people unless we are concerned that someone is in danger. As Dr. Harsha mentioned, that if there is some intent of self-harm to yourself or to others, then in that situation, the confidentiality needs to be breached. So what is assent? Assent is defined as an agreement from someone who is yet not of legal age and is not able to give a consent to participate in particular activity. And the consent is given by the individuals who have reached the legal age of consent. Wherever assent is taken, in that situation, the surrogate guardians like the parents or legal guardians, their consent has to be taken. So engaging adolescent communication is the key to success. And there are certain do's and don'ts of effective communication. The golden rules are: stop talking, give them time and attention, put them at ease. There should be no jargon. The language should be in which they can understand. There should be sincerity. Be interactive, that means give feedback, ask questions. Reflecting, listening. Listening is a very important aspect of effective communication, and it should reflect, it is reflected in by the tone, the ideas, the words, and the non-verbal cues. That is, posture, the body language, eye contact. These are all non-verbal cues of effective communication. Never assume or judge. Always ask open-ended questions so that the conversation can be continued. Always build a trusting relationship, empathize with them, be self-aware, sensitive to the impact of the language and attitude, and allow them to educate and inform you. There are many protective and risk factors. Protective factors act as a buffer to any negative effect of risk factors, and they interrupt the risk chain and prevent the initial occurrence of risk. So the protective factors are connectedness at the level of school, peers, and community, a caring family environment, supportive relationship with at least one trustable, caring adult, achievements and sense of belonging in the school, social skills, positive self-esteem, sense of purpose and meaning. The risk factors are socioeconomic disadvantage, poor parenting, family conflict, breakdown, school failures, bullying, lack of meaningful relationships, resulting in low self-esteem and poor social skills, exposure to trauma, violence and crime, even sexual abuse, refugee experience, racism and discrimination. These are the risk factors. And at the protective factors can be at 4 levels: the child, family, school, and the community. So secure attachment experience, good communication skills, family harmony and stability, positive school climate with clear policies on behavior and bullying, wider supportive network in the community, and range of sport leisure activities at the community level. So we have the psychosocial assessment, which comes under the acronym HEADS. It is a practical time-tested strategy that can be used to obtain a psychosocial review of systems for adolescent patients who attend your clinic. So H stands for home, E for education, E for eating, A for activities, drugs, S, the 3 S, one representing sexuality, S for suicide, and S for safety. So we will take them one by one. Home. We can start with the first question: who lives in the home with you? This is written in bold because the answer to this will dictate the rest of the interview. Keep the question specific, allowing the patient to or the client to expound when needed. So if you can talk about the relationship with the siblings, parents, or with grandparents, what are the rules like at home? Is there any gun at the home? Ever being homeless or in a shelter care? So these are the factors which will help us tell us about the protective as well as the risk factors. So education and employment. What kind of student you are, how many days you have missed in the past year, and what are the reasons? Have you ever had any educational setbacks, and what is the reason behind it? Have you had recent school changes, and what are the educational and the life goals? Coming to the employment, some children these days have to, under the COVID circumstances, they had to take up part-time jobs also. So if they're working, you have to ask them what type of work they're doing, how many hours a week, and are they being paid for it? What are the future career interests? Are they doing any home chores? Adolescents are often employed part-time and time during school year, and they're because of the inadequate resources. Activities, whether they are attached with some, sports, are there in, spiritual activities, how many hours of television, computer per day, per week, because now screen time is also very important to know, and how many hours they spend on the social media. All these have an effect on the growth of the mental growth of an adolescent. Now, one thing you have to remember that we start for the heads, we are talking about less sensitive questions. And once we gain the confidence and the trust of an adolescent, we progress to the more sensitive questions. And what are they? Drug and alcohol use. So in shifting from the non-sensitive, more general questions about home, activities, etc., we question regarding drugs, alcohol, and sex. It is important to acknowledge that a shift has taken place. Explain to the adolescent that why you are asking about these behaviors, and once again, secure confidentiality. Because if you do that, they start opening up. Most adolescents experiment with drugs at some point in their development, whether limited to alcohol, caffeine, and cigarettes, or extended to marijuana, cocaine, and hard drugs. Adolescents who use drugs to manage stress are of particular concern, as this can interfere with coping skills and responsible decision-making and lead to lifelong addiction. And we should also ask about the over-the-counter prescription drugs if they are using it, or for that matter, erasers, the thinners they can use as drugs. So does anyone, you hang out with smoke, drink, or use drugs? Does anyone at home use tobacco and alcohol? Because they've got easy access to it. And then you can ask them, do you also do it? And if they do, how frequently and how much? Do they chew or smoke tobacco? Do they use anabolic steroids? With the culture of the gymming, so many children, especially boys who want to pump in muscles, they're using anabolic steroids without being aware of the consequences, drastic consequences. If you drink alcohol, it's very common these days for a adolescent to experiment with beer, wine, and even hard liquor. Are there any blackouts? Have you ever passed out, vomiting? All this will give us cue to the sensitive questions about drug and alcohol use. Now, there are certain alcohol use you can use the craft. This is away from the heads, this thing. C stands for, have you ever ridden in a car driven by someone who was high or had been using drugs or alcohol? R stands for, do you ever use alcohol or drugs to relax? A, do you use drugs or alcohol when you are alone? F, do you forget things you did while using drugs or on alcohol? The other F stands for, do your family and friends ever tell you that you should cut down your drinking or drug use? And T stands for, have you ever gotten into trouble with the law? So drugs and alcohol, marijuana, inhalants, cocaine, crack, heroin, pills, LSD, ecstasy, crystal meth, and other drugs. And these days, the vaping, that is the cigarettes which are nicotine free, but they have the more not nicotine free, but there are a lot of nicotine in it. So we have to know, this is the latest trend which has come up. So have they ever received any treatment or counseling for drug intake? Now, the other D stands for the depression and suicidal. It is important to screen all teenagers for depression, not those who may look depressed. Suicide, as you know, is the third leading cause of death in the age group of 15 to 24 years old. Though females are more likely to attempt suicide, males are about 3 times more likely to succeed in it. This occurs because of the choices more lethal methods for attempting suicide. Estimates indicate that for every successful suicide in adolescent population, 50 attempts are made. So suicidal adolescents often have depressive symptoms. So there is an overlap. As a sense of hopelessness, low self-esteem and high self-blame are associated with adolescent suicide. So depression and suicidal, you can ask about what is the usual mood, whether they're happy, sad, or both. Are they bored much of the time? Whatever activities they were doing, and suddenly they've stopped doing that. So that is the thing that they are depressed. Are they having trouble sleeping, eating, or they're feeling sad after using social media sites, which they used to enjoy earlier, like Facebook, Instagram? They may be fact that they're being cyberbullied and they're internalizing and the self-esteem is low. So are you coping well, or you are feeling stressed all the time? Are you thinking of hurting yourself, or have you tried to hurt or kill yourself? Whom did you tell? These are very important. And there is a very simple 2-question PHQ-2 screening tool for depression. And in those things, you ask that little interest or pleasure in doing things, not at all. It is considered as 0 grade. Several days, 1, more than half days, 2, nearly every day, 3, and feeling down, depressed, or hopeless, the maximum is 3. So these 2 questionnaires, score of 3 or greater, has good sensitivity and specificity for detecting major depression in adolescents. Sexuality, Dr. Latika has already touched it. So very important to ask questions regarding their body, sex, pregnancy, and the sexually transmitted diseases. Discussing sex with adolescent patients in the clinic or office settings often provides opportunities for personalized information and for confidential screening of risk status and for health promotion and counseling. Prevention and counseling can be targeted to the needs of the youth who are and who are not yet sexually active. So you should ask about that the sexual identification does not always match with the behavior. Sometimes they're just exploring, and once they grow out of it, they will have their own identity and gender identification will be there. So what do you have to ask them questions regarding, are they aware what is the safer sex and what does it mean to them? Have they ever sent any photographs of their on email or internet which are compromised? Have you ever been touched sexually in a manner you don't like? Have you ever been raped on a date? History of sexually transmitted diseases, even the menstrual history. What is their sexual orientation, gender identity, age at first intercourse? Are they aware of it? Vaginal, oral, and anal sex history, contraceptive history, pregnancy history. There are several components of sexual reproductive health history. So we have to touch according to the flow of questions and how they respond. So we should assure confidentiality while taking sexual history, explain why you are asking sensitive questions, ask patient to describe specific sexual behaviors, add second tier questions to assess comfort with behaviors. So you can ask, do not ask that are you sexually active? Use gender biased pronouns when referring to sexual patterns, use judgmental language, use slang, unless patient offers it first. So these are the do's and don'ts of taking the sexual history. Assessing gender identification, it includes understanding one's existence as male or female and the roles and responsibilities of being a man or a woman. Now, assessing the health of a relationship, it is very important to ask about the relationship, because these days, more or less, even the other day, there was a 13-year-old girl who said she has a broken relationship. It's very, we have to accept that this age, teenagers are into relationship. So we should ask them, what is their concept about a healthy relationship? Are there any disagreements and arguments in a normal part of any intimate relationship? What is it when you and your partner get into an argument? How do you resolve it? How many times are you together, and who makes the decisions and about when to have sex, and if what type of contraceptives have you ever considered using? So is there any sexual and physical abuse? Have you ever been forced to have sex or being touched in a way against your will? By whom? And it's still going on? Who did you tell? How does it affect your day-to-day life? In what ways does your experience affect your sexual relationships now? There can be interpersonal violence which includes battering, domestic violence, partner violence, school, peer, community violence, that means physical bullying as well as cyber bullying, sexual harassment, abuse and assault, and even hate crime. So look deep. Many adolescent problems are interrelated, and interventions are one area can lead to positive outcomes in other areas. Presenting problems may not be the main problem. It is just the tip of the iceberg. So additional safety concerns, recreational activities, do they wear helmets, protective sport gear or the auto safety riding while using a seat belt, simple as a seat belt? And do they have any access to the guns? Do they ask if the adolescents have access to all these things in the household? Spirituality, what do you consider regarding the religion? How often do you participate in religious activities? How important are the spiritual beliefs in your day-to-day life? Because all this spirituality can be used as a protective factor in protecting your adolescent. Assess healthy behaviors in resiliency through the interview. Identify past difficulties that have been overcome, provide positive feedback to balance the interview, be sure to praise the adolescent when you find such a positive in the history. A little bit of positive reinforcement goes a long way toward improving self-esteem and cementing a positive, trusting relationship with the young person. Compliment on the strengths, highlight the areas of concern, invite questions, discuss who's to be involved in referral or follow-up, discuss what to tell and not to discuss with parents, provide feedback about your assessment. And some things which you can make resilient adolescent is at the home, connectedness, caring parents and family, care of siblings, other relatives, and the education and employment better than average school performance, strong participation in extracurricular school-related activities, including sports, activities, that means leadership among peers, drugs refusal skills, sexuality refusal skills, and consistently responsible sexual behavior, access to a confidant, successful coping skills, no family history or parental history of attempted suicide. Safety is conflict resolution skills, substance-free seat belt and helmet use, refusal to drive in cars with potentially intoxicated drivers. So empathize with the situation, validate their feelings, take an open stance, be interested in them, take time, don't blame them, label them, example, non-compliant, use reflective listening to build rapport. My guess is that you're not too happy about being here today. You can start off like that. Be collaborative, ask them to help you understand. Example, I'm not sure if this is correct. Have I got it this right? So validate their feelings. Don't take challenging behaviors personally. Avoid being authoritarian. There should be no power struggles. So anticipatory counseling, help the young person identify and weigh up the costs and the benefits of behavior, explore reasons for engaging in risky behavior, explore alternative ways to achieve the same benefits, explore the possible harmful consequences of behavior, anticipate the barriers to change, example, peer pressure, identify strategies, and teach skills for reducing harm, example, assertiveness, planning ahead, and decision-making, cognitive rehearsal, that is practicing refusal skills. So this is just a simple case. A 15-year-old female patient comes to your office. You notice that she has gained a bit of weight. When you ask her to stand on the scale, she begins to cry. What questions do you ask her regarding her health and body weight? How do you approach the subject sensitively? Explain that during puberty, many girls may gain weight in specific areas of their bodies. So there may be body image issues. Are you happy with your weight? What do you think your ideal weight should be? How many meals do you eat per day? Because there may be eating disorders, which may be any spectrum. Obesity may be there, anorexia nervosa may be there. Do you ever skip meals? Have there been any change in your eating patterns in the past 3 months? What do you do for exercise? How many things are at home? Assess for possible abuse, refer patient for nutritional counseling, schedule, follow up. So this is just a simple example of a very simple case of eating disorder. Thank you.
Thanks, Dr. Deepa. That was an excellent scientific deliberation about how to deal with a adolescent and how to identify troublesome adolescent. You have said, rightly said, our adolescents sometimes behave like an adult, responsible, very careful, very energetic, and very sensible. And sometimes they behave like an immature child. Home environment is important. There is a definite impact of the parents' attitude, elders' attitude, as well as the teacher's attitude, which helps in grooming a young adult. We sure cannot be judgmental, and we should never try to be judgmental. We have to be friendly, have an open discussion with the adolescent, empathize them, and try to help them grow into a sensible, intelligent, vibrant young adults. Any comment, Dr. Gangadhar Sahu, from your side?
Yes, Mala madam. Actually, there is, this is just as I said, the most important change in the life cycle. So any change is definitely welcome, and it is challenging to manage it. So in my view, there's it's not a rule of thumb to educate any particular adolescent who is facing a problem. So each case is different. Therefore, what I give importance is as I say, always say, charity begins at home. Therefore, home environment is the best one. Second is in the schooling and college, the relationship and the friend circle. That is more important. Therefore, the teachers, parents should keep an eye on this. What type of friends the girl has or the boy has. So therefore, they can know. Now, drugs, alcohol, smoking, all these things, it is creating a havoc in the society. So therefore, adolescent problem is not an individual problem. It is a family problem. It's a social problem. So that should be looked in that aspect. At every step, the parents, grandparents, teachers, the society should take care of these issues, and that should be nipped in the bud. Thank you, madam, for giving me this opportunity.
Dr. Bhalla, you're mute.
Dr. Harsh, you want to say a word?
So yeah, it was a very good lecture, and see each and every word Dr. Deepa said, it was very important. See, I think the pediatricians or the psychologists, they can be the change by having the knowledge of the risk factors, assessment and detection of the high risk adolescent groups. And we can always help them. And yes, as Dr. Gangadhar Sahu said, that it's a home environment, school environment, and one should know, I think parents should know that in which group your child is roaming about. What are his friends are like. And secondly, they can also have the knowledge of the family of the friends, because sometimes the friends' families, they can be having something, very high society like that, and something wrong. So I think it's very important that one should know, that one parent should know that in which circle your child is this thing attached to. Thank you very much, Dr. Deepa. It was very excellent lecture you've given and very interesting. And the topics are really very, very interesting. And Dr. Chandra, it's congratulations. I think you have selected very good topics. Huh?
Thank you, Dr. Harsh, for your kind words.
Thank you, ma'am. Thank you.
Thank you.
We thought we should discuss this untouched topic.
Yes.
And yeah, we should, because every day we encounter these young girls and we don't touch this aspect of the life.
Yes.
So I thought we should touch this topic.
Right.
And there was a great support of Dr. Latika Bhalla. She suggested this topic was actually brainwave of Dr. Latika. So I thought, yes, this is untouched topic. So that is why we chosen this topic.
We had a very nice session with Dr. Latika and Dr. Deepa. And I think we shall hand over to Dr. Renuka for the next session.
Thank you, Dr. Mala, Dr. Harsh, Dr. Gangadhar Sahu sirs for joining us today and for conducting such an informative session. And I congratulate Dr. Latika and Dr. Deepa on their wonderful presentation on adolescent sexuality. Next, we will have a panel discussion. And for this panel discussion, I would as a chairperson, I would like to invite Professor Dr. Anurag Agrawal. Can you show sir's CV? Yes. He is Professor, Department of Pediatrics, Maulana Azad Medical College, GB Pant Hospital. He is Executive Board Member, CIAP, President-elect IAP Delhi 2022. And he has published more than 30 research papers in national and international journals and chapters in books. As an expert, I would like to invite Dr. Sangeeta Yadav, sorry. She is Director Professor, Department of Pediatrics, Maulana Azad Medical College, UCMS, and she is working as a Joint Secretary CIAP, and he has attended multiple meetings on the behalf of IAP for Child and Adolescent Health with government ministries, NGOs, and international agencies. To moderate the panel, I would like to invite Dr. Aradhana. She is Associate Professor, Department of Pediatrics, UCMS, Delhi. Her special interest is in pediatric endocrinology, and she runs pediatric endocrinology clinics at UCMS and GTB Hospital. Welcome, ma'am, Dr. Aradhana.
Okay, thank you for the kind introduction. Very good evening to all, and thank you for the organizers and Dr. Latika Bhalla madam for giving me the opportunity to moderate this panel discussion. Dr. Sangeeta Yadav madam and Dr. Anurag Agrawal sir will join soon as they are returning from Pedicon. So let's start with the panel discussion. For this discussion, we have very knowledgeable panelists with us. Can you show please the okay. So Dr. Swati Ghate, she is pediatrician, adolescent health specialist, and clinical psychologist, Joint Director, Baby Launch Newton ICAD Jaipur. She has been National Coordinator, Scientific Committee HA 2022, Convener CIAP Task Force 2020, 21, and 22. She has been Coordinator DIAP Webinar Series for Parents and Teachers. She has also been Associate Editor of AHA IAP Textbook on adolescent-friendly pediatric practice. She is academic editor and contributor to a number of teachers module and AHA. She has been researcher and writer also. She has contributed to a number of journals and pediatric textbooks. She has contributed to IAP Mission, COVID, MSU, Parental Guidelines, IAP Standard Treatment Guidelines. She is faculty and master trainer of MKU, AYA, COVID, MSU, Adolescent Counseling, a number of conferences and webinars also. So, so can we start? Over to you, Dr. Swati.
Thank you so much, Dr. Aradhana. Many thanks to the organizers and also to Dr. Latika, and my respectful regards to all the august seniors over here. The stage has been nicely laid down by Dr. Latika and Dr. Deepa, and now in this panel, we would be discussing something more practical and how to apply all this knowledge into practice. Right, Dr. Aradhana?
Yes, please. Are you able to share the screen?
I I think I'm not able to share, and it's good if you could share it. Just
Yeah, I will try.
Dr. Swati, Mr. Vinod has your slides. He can share.
Dr. Aradhana also has my slides, madam.
Okay, okay, no issue.
Is anything visible?
Yes, it's visible. You have to click the PPT. The list of PPTs is visible.
Yeah, I will try just. Is it okay?
It's not yet open. Please open the PPT.
Yeah, I have opened from my side.
No, ma'am, it's not open yet.
We can see the list of the PPTs.
Yes. Please go to the
I'm doing.
slideshow mode. So we are going to discuss something regarding teen romantic relationships in the context of sexuality that we have been discussing in this webinar. There are many news items that are flashing in the newspapers and other social media, which are telling us loud and clear that yes, teen romantic relationship and associated sexuality concerns are on a great rise. There are also many legal issues and entanglements, and that has made so much of a hue and cry about the teen romantic relationship, which are so very common, and as has been already told time and again by all the experts who were interacting in the webinar till now. So they're not able to go to slideshow.
It's
Dr.
not
Aradhana?
here actually, this option.
Here it is in the at the top.
Yeah, but nothing. I'm not able to click anything.
Okay, so if you could see it from the bottom.
No, it's. I don't know why it's not visible. It's light sorter view and normal view only.
Okay.
Should I try again?
Yes, please. So till that time, I'll let you know what are the generally the cases that are coming to us as adolescent health specialists, which are concerned with the teenage romantic relationships. So there was a child who was brought to me. He was a 10th standard student, and he had written a love letter to a neighbor who was studying in the final year of graduation. So the girl, he told it to the boy's mother, and the mother told to the father, and the father gave a nice beating to this boy. So this boy was brought to me, but I was really wondering who all need to be educated and who all need to be empowered regarding adolescent sexuality and adolescent romance. Another boy who was brought to me was Bhavesh, was a second year student. He had a broken relationship few months back, and then he started consuming alcohol to cope the loss, and then he was now a regular drinker. Another girl who was brought to me in the very recent past was a girl of 17 who was like behaving very abnormally. That means she was all the time depressed, and when I went through the hedices, I got to know that she is feeling something very unusual and bizarre for her best friend. Till now, she was not feeling anything like that, but now she is afraid to share it with her friend because she has a feeling that the friend might leave her forever. And when she discussed all these things with her close cousin, she told her that since you are not in a co-ed school, you are in a only girls school, you are getting such thoughts. So she was very much annoyed with her father and mother that they chose only girls school for her and made a mess of her life. So these are certain types of cases that we come across, and they totally show us that how important it is to throw light not only to the teens but also to their caretakers regarding this important issue. Thank you, Dr. Aradhana. I think we can move ahead now. Sorry for the technical glitch. Yes, this was, yes. The other case was of a 12-year-old girl from a conservative family who was caught by her mother sexting something to her boyfriend. So she was brought to me to so that I should tell her something. I should give some pearls of wisdom to her. So this is all we are we are going through. Next, please, Dr. Aradhana.
Okay, so sorry for the glitch. So how do you go about with such patients, Dr. Swati?
Yes. So there is as just now Dr. Deepa has elaborately mentioned, there is a typical pattern and like a scientific way of addressing these issues. How we approach to an adolescent is very, very important. We cannot just try and start the way we deal with either very young children or the adults. So to elaborate this, I have taken up this case. She is a 14-year-old girl, Reena, who was brought by her mother for pain in abdomen off and on since past 2 months. There was no history of any other physical ailments which could be explained in the form of fever, loose motions, vomiting, or menstrual issues. But the mother, on asking, said that yes, she has seen that the child is not engaging herself in studies or she not going out with her friends. So when we take up such cases in our practice, we interview the adolescents and the parents first together and then individually. The privacy, confidentiality has already been explained. We have to be completely non-judgmental about whatever they come up with, and an empathetic attitude, wearing their own shoes and looking at in their perspective to the case, to the situation is very, very essential. Then along with HEDISIS, we also have to carry out the mental status examination if needed, physical and systemic examination, and relevant investigations. This is the flow.
So what were your findings in Reena's case?
Yes. So in Reena's case, since she presented with the physical complaints, I had first to rule out any physical issues that she is suffering from. So in the examination, she did look apprehensive and was avoiding eye contact and answering in monosyllables. Otherwise, the general condition and the vitals and the USG abdomen she was already carrying, it was all normal. So I then, with complete confidentiality, headed for a HEDISIS examination. Next, please. So in this examination, we just now Dr. Deepa has told that all these details are taken on home, eating habits, education, activities, drugs and all. So I came to know that it was a family wherein father was over busy with his business affairs and he was a dominating sort of a person. The parents frequently were arguing with one another. Education she was showing falls in grades recently. Activities, she had stopped practicing the basketball, which she was very fond of. Next, please. So sexuality history, when we try and try to elicit the history from them, we have to tell that I'm going to ask you some personal information, which you may find little awkward, but this is very essential for me to know because I can help you better. So in this case, the menarche was attained by the girl 2 years back and her cycles were regular and she was happy being a girl. She confessed that she's in romantic relationship with a senior boy of 17 who is her schoolmate. He had made some physical advances which she enjoyed, but there was no physical sexual act. And now that boy has started demanding more. And that has made her very restless, sleepless of late. She has lost her focus and she was afraid of either how do I confess with my parents? What if they come to know? And whether there's any chance of pregnancy by what they were indulging into. She was not into sexual intimacy, but when there is a sexual intimacy history, we have to also take into consideration all this detailed history regarding partners, regarding what practices, protection from STIs, any past history, and any pregnancy prevention plans that they have. So next, please.
So what was your diagnosis and how did you manage this case?
So regarding adolescent health, it is very important to know that maybe we will not be able to come at the diagnosis in the very first go. We have to have multiple sessions with the child and the family and gather a lot more information before we give a diagnosis. So my impression was that she's a distressed teen, she's under stress, and she's presenting with psychosomatic complaints. She is an ill-informed teen and her life skills are not up to the mark. So with this, I headed for the management. The first comes empowerment of the adolescent. Before the empowerment, what is needed is validating the feelings. Yes, whatever you're feeling restless, you're feeling very apprehensive, you're feeling not so good about the boy, it's absolutely okay. Then, as has been discussed, we have to provide correct scientific information and teach the life skills. So when we share the information, it has to be emphasized that why we are sharing and why we are telling you is only because of your own safety. We are not preaching anything, we are not directing anything, but we are just worried about your safety and we are concerned about you. Then making them comfortable while talking about sexuality is also very important, and this could be achieved after building a good rapport. Then sharing relevant information by priority is important. What is it that is bothering the teenager? That has to be taken up in the course of discussion. Use of authentic sites, books, posters, videos, PPTs, any Insta reels, any role plays. If we are talking to the teen as groups, role plays really make a lot of difference. So these are the things which we may use to empower them. Anticipatory guidance on aspects that are related is also very important. Then awareness about child rights, legal implications of what they are doing, and at the same time empowering peers and caregivers is also very important. So in Reena's case, the relevance was regarding sexual experimentation and the pressurization from the boyfriend. So we would like to naturally empower her about what is sex and why such an urge in this age, something about relationship, how to express the feelings in safer way, what are the sexual rights of a child, dating abuse and violence, date rape, drugs, and POXO. So this is all that we have to talk about. Now she is in the middle adolescent and she has a lot of urge to experiment. So these children, there is always a inhibition that how to tell what is sex and how to talk about it. So I always take the example of the flower pollination, which they already know. I try to tell them that when male and female gametes have to meet, there needs a sort of a carrier. It could be an insect or a water or a wind. When the trees are when the trees are not close by, but when creatures can move, they go close by, and then the gametes are shared. So this act of sex is for reproduction. It is for continuation of species. Then it has to be pleasurable for both the partners. And in this act of intimacy, you are expressing your love and deriving as well as giving pleasure. So we make it very clear that you should not fall prey to anyone else's pleasure demands. It should always be with consent, and the one without consent or without knowing that it is sex is something which is very, very dangerous. So the next and a very important thing is plants and animals, they do not indulge into reproduction unless they are mature and able to handle themselves. And so till the time when our body and mind is not ready, we should not be having any indulgence into physical intimacy. Next, please. So why you people are so much vulnerable, that also has to be shared with them because of the hormonal surges, because of the curiosity and experimentation, which is so very normal and natural. Then they have certain other peer influences, like they want to impress others by having a boyfriend and having an intimacy with him. Peer pressure, being in fashion, that is the trend of the day, need of the day, all these things that they want to fit into the peer group, and so they indulge into that. They sometimes think that it is the only sign of love that they can express. Porn watching and media influence also rises their experimentation. Under the influence of drug, yes, anything can go wrong. Lack of knowledge, and particularly that of POXO, is also very, very important cause. Sometimes the teenagers are under so much of a stress that they take up sexual intimacy as a coping strategy. Children who have poor self-esteem or who are troubled at home, they are more likely to experiment in this way. So we tell them that there is a fulcrum which we can turn to our favorable side by being correctly knowledged, by having our own values and ethics and health concerns, rather than the thrill, peer pressure, or group conformity. Suggesting safer ways is also important, and telling them that intimate talks, long walks, holding hands, dancing, kissing, touching, and hugging are all safe ways to connect and share affection. Next, please.
So how to decide that a relationship is healthy?
Yes. So many times children feel that the crush that they are going through is the ultimate love, and it is something very divine. But a healthy relationship starts with friendship, goes on to love, then marriage, and then sex. It is the pyramid that we have to tell us from our own angle and from our own safety concerns. Then there are healthy, unhealthy, and abusive relationships. The healthy relationships has open communication and concern for one another. In unhealthy, there are many disagreements, and in the abusive, people are not equal. One partner takes over and he tries to control the situation every now and then. And this is something which we need to teach them and be aware about their own relationships. Next, please. So a wrongly timed attempt of sex could be devastating. That is the message that we have to give them. So when between the crush and love, the focus on the body and focus on the personality, being in the crush, that they feel that they themselves need to be satisfied, where in the love, the other person is important. Family, everything is shared in love. If it is a good commitment, that they are not afraid of sharing it with family, but in the crush, there is avoidance to share with the family. Crush is for short-lived discomfort, whereas love is for a long-term commitment, and breakups could be really traumatizing. All these things we have to explain them naturally in a very proper way. And for this, I always use this a picture. Dr. Aradhana, could you click once? So crush is the thing where you just pluck up the plant, not caring about it, and just use it the way you want and throw away. But whereas in love, it is the plant that you water and you care for, and probably you will not pluck its flowers. So this is how you have to talk with them, the way they understand and they will find interesting. Many life skills need to be trained to children in like self-awareness, what I want to do in my life, decision making, whether it is good or bad to fall prey to his demands. Next, please. Then defending yourself is not offending, assertiveness and controlling impulses. And there are many more communication skills, and there are many more life skills that we need to teach to our adolescents for their safety. So romance versus sexual abuse. This is the pink film, and no means no is loud and clear message, and any form of forced sex, even from a boyfriend, is also rape. Alcohol and drugs weaken the thinking and decision making, and a date rape is very common. So we have to always tell them about the pregnancy and STI. So how to say no? You could share some values, ethics, and religiosity reasons with the boy. You could give your uh, physical harm or to the growing body as a reason not to indulge into sex, then you can elaborately tell him that I am afraid of having pregnancy and diseases. You could buy some time by saying some other time, maybe not today. Then you could quote reasons like career and scholastic, having some issues with the children, with the school teachers, if they discover all these things. Forcing sex is not love is the message that she has to share with her boyfriend, legal implications, and she should be ready to part if the boy doesn't accept what she says. And taking help of caretakers and counselors is also very important. Now, the role of contraception. We generally do not prescribe contraceptives, but if the child is not ready to stop at that junction, maybe we have to advise using contraception. Then cybersexual abuse comes in various forms, in the form of sexting, demanding objectionable photos. I think Dr. Deepa has covered this. We can move ahead. Regarding POXO, what information we share is the age of consent for sex is 18. Now there's a big debate about bringing it to 16, but yet the law is not there. So we have to keep sharing this information. Sex below 18, even with consent, is crime. It applies to all under 18, may it be victim or accused. Reporting is mandatory. Whosoever knows that a person has been sexually in relationship, you have to report it. If the child, victim, accused, anyone is under 18. The proceedings are very, very child friendly. There are trained lady officers who come and take the history. Burden of proof is with the accused and not the one who is sufferer. Defense lawyer cannot ask direct questions, and it is only through the magistrate that he asks questions, and the punishment is really severe. And if he is the caretaker, then the punishment is still higher. So there are these authentic sites, and there are certain apps that UNICEF and WHO have developed to empower our adolescents on their sexual life, sexuality, and there are certain links that I have shared here. So thank you all for your patient listening, and I take this opportunity to thank all my teachers and friends in IIP and AHA family for giving me this opportunity to be able to share all this knowledge. Thank you so much.
Dr. Aradhana, can I ask one question to Dr. Swati?
Yeah, ma'am, sure.
Yeah, Dr. Swati, you described really very well, and it's eye-opening things. Though we being in contact with the young girls, we don't know all these facts. But I want to know how many times you felt you failed to explain these things to the young girls who are coming to you, or you feel whenever you explain them, you counsel them, and they feel empowered and they want to revert back, or they want to pursue a good life, or the safer life, or they are able to say no for the sexual contact. Or
yes, many times, even in this case, after 4 or 5 sessions, this girl had all the courage to tell the boy that I am ready to part, but I will not go into a sexual intimate act. So it takes quite a lot of time. It is not a one-time thing.
Yeah, I can understand.
Because you have to build a rapport, then you have to take. So it is a long process, but we are successful.
Confidence in the girl. Then only she will open up and she will talk to you like a friend, and she will take her advice. Then only she will be able to take her advice from you. Otherwise, she would not open up and in 1 or 2 visits.
Yes.
So I think every time. Yeah, so every time you have to tell them, say no to the sex, like this, or you have to explain, no, nothing.
No. We cannot be preachy. That what we want to tell you is this. Decision is yours. Decision is yours.
Yeah, Dr. Swati, sometimes being a gynecologist, I feel when I talk about the contraception to the young girl less than 18, means we are giving them permission to, okay, you go ahead and have sex, but use the contraceptives. So I feel like
that's what when we in the adolescent health, we always be flexible. We cannot be very rigid, because that doesn't stop them. If we say that no, you don't do anything, you don't indulge into sex, we are not sure whether they will follow our advice. So we always try to tell them that it's not fair or it's risky to indulge into sex. But if at all you have to indulge into sex, you should take a step ahead to protect yourself.
Yeah,
That is how we go.
Yeah, absolutely. Thank you.
Thank you so much, madam.
Thank you, Dr. Swati, for such an interesting and very clear talk. So we have learned that romantic relationships have much to teach adolescents about communication, emotion, empathy, identity, and it boosts up their confidence also. However, in the absence of proper guidance, such relationships may even have untoward consequences. So proper guidance is required, and Dr. Swati has covered very important points on this aspect. So thank you very much.
Thank you so much. Thanks.
Thank you. So moving on to our next topic, Dr. Sunita Manchanda, please share. Yeah. Dr. Sunita Manchanda is a child and adolescent specialist at Gurgaon, Jain Sant Phoolchandji Charitable Hospital. She is associated to NGO Arya Bal Kalyan Kendra, Association of Adolescent and Child Care India, Adolescent Health Association. She has been past president, Indian Academy of Pediatrics, Gurugram, 2020-21. She has been state coordinator, basic NRP, 2017 to 20. She has been regional trainer for IAP, NNF, NRP, FGM project, and has contributed to various self-learning articles by IGAP, by AHA and AECI. So Dr. Sunita will be talking about gender dysphoria, which is another very neglected aspect of adolescent healthcare. Over to you, Dr. Sunita Manchanda.
Yeah, hello.
Yeah, are you able to share?
Yeah, it should be. Last time I was. Just 1 second. Give me a minute. Yeah, is it coming?
Yeah, it's coming.
Slides are visible?
Yeah, just make it a slideshow.
Okay, fine. So, good evening, everyone. Just give me, I am not able to see all of you, sorry. Right.
Dr. Sunita, we all are there.
Yeah, I know. So, first of all, I would like to thank Dr. Latika for giving me opportunity to be a part of this, and also would like to thank you, Dr. Harsha ma'am, Dr. Mala, and Dr. Chandra for organizing, talk on this topic. As we are running short of time, so I'll be trying to be very quick and little bit fast. If anyone feels like it is little fast, then let me know. I'll be slow. But otherwise, well, today's topic is gender dysphoria. The talk is, my objective is to bring about sensitization to our pediatrician, gynecologist, and healthcare professionals. Reason being, I want to share one experience when we were attending that conference at International Adolescent of International Conference on Adolescent Health. We attended a session which was being conducted and organized for transgenders and all these people who are little different from where we cannot define them male and female. The thing they said was, the experience when they were sharing is, they said, oh, we talked to our parents about it. They were not listening to us. We went to the doctor. Doctors were very horrible. They were so, rude to us. And we were there to stand there and then let us told our point of view that, see, we are also from the same community from where you are. We are also not aware of the things which you are facing. So at that time, we could, point out our point of view, but more important was us that we have to find a way of, something where we can help them. And this is the first step towards, getting awareness about this topic by myself and making others to know about this topic so that we can help these people to come out of their closet, which is very important. And society can accept these people when their parents, their doctors, and everyone else will try to help them to accept that. So having this, again, thanking for making this platform, for bringing this sensitization, bringing this topic for sensitization. So, yeah.
Okay, just a minute. Just make a slideshow.
Okay.
Yeah.
Yeah.
Okay, so can you describe what is gender dysphoria? Because many of us don't understand the difference between gender dysphoria, homosexuality, and all these terms.
Yeah, exactly. Like that is what I would say. Defining again has been a very problematic for these kind of papers because exactly we do not know, about this topic. So thanks for putting this question, Dr. Aradhna. As they say, there has been many terms from the beginning. Not going into that details. Previous term was gender identity disorder, which was like used until 2013, where this DSM-5 came. We don't want to use that term for the people who have distress. This is very important word for them. A person experiences due to a mismatch between their gender identity, that is a personal sense of their own gender and their sex assigned at birth. As we can see in the picture, he is a male as by looks, but what internally he thinks about himself is a female. And this not being a part of, like, he thinks differently from what he is, has caused a distress. That is very important because there are people who accept this situation and go on with their life. Okay, it's okay. But definitely there is a distress which is help asking him to take action, action, action. That is where we use the term gender dysphoria. Definitely now it is not considered as a disorder. Initially it was being considered as a pathology, but now it is kind of a getting accepted into the society. Now, if we go into the DSM-5, not going into much of the details because everything will be on the net. It is just there are two components. One is I am a male by sex, by my genetic makeup, but I don't want to be a male. Another is I want to be a female. So these two components, if we keep in mind, then what happens is if I want to be a female, being a male outside, children's who are boy, but they would like to play with girls, they would like to play games or the things which generally girls do. So that is the main thing that they do. Second is that because they do not consider or they do not like being a male, they would be angry or they do not like someone calling them, boy. So they will keep on asking, saying, I'm a girl, I'm a girl. So that is what they do not want to get. They do not want to get, play with the masculine toys, games, activities, etc. So apart from these two components, if we take into consideration, their preference will be playing the roles or the games of the other sex. Like girls will be interested more in the car racing, etc., or boys will be more into the kitchen works, etc. Though these difference has been coming, being going down also in our society. Then strong dislike of, along with these components, strong dislike of one's sexual anatomy and strong desire for physical sex characteristic that match one experienced gender. That happens in children. In the adolescents, again, these are the similar things which then convert into a strong desire to be a gender other than the one's assigned gender. Strong desire to be treated as other gender. And then there is a definitely incongruence between experienced or expressed gender. Like, for example, if a male, he's like physically female and now, but mentally or, internally he thinks that I'm a girl. Sorry, she's a girl by sex and he thinks the male. So what they do is, like, if they develop the breast, when puberty happens, they try to put that binders, etc., so that it will not visible. So strong desire for the sexual characteristic of a gender of the opposite gender, and strong desire to rid of one's sexual characteristic due to incongruence with one experience and expressed gender, and strong conviction that one has typical reactions and feelings of gender other than one's assigned gender. This definition, seems to be a little bit complicated, but once we understand the concept, then it is easier to, understand. And these characteristics should be present at least for 6 months duration. So it's just a quick view about child gender dysphoria and adult. So like in the child in generally, if the kids say कि मैं ऐसे करना, तो we used to say girl है तो हम लोग भी बोल देते हैं कि tomboy kind of feeling. Boy है तो it's like, you know, pussy or sissy, the terms we can use it in a casual way. But if it is a strong desire to be other gender or insistence that one is other gender or preference of playmates of other gender and strong preference of cross gender roles in make-believe way in child gender, then be a little alert. And in the adult, again, I have already explained. So basically, this is the, in general, dysphoria. But along with that, because we had defined it, but still there are terms which always, come across. Cisgender is again that we all are. Gender expression is the way the people outwardly express their gender identity. That is what we do. Like girls hai to wo kapde pehenne ka dhang different hai. We all know that. But of course, ये difference change होता जा रहा है with over the time also. That is why it is important that whether this distress is there or not. Gender identity is person's inner sense and experience of their gender. Non-binary is an umbrella term which we describe about agender, androgynous, bigender, pangender, gender fluid, depending upon their internal as well as external reproductive organs and external sex characteristics. Again, similarly, gender is umbrella term to describe someone who identifies as a gender different from one they were assigned at birth. And in April 2014, the Supreme Court of India declared transgender to be a third gender in Indian law, which is normally being written in the forms, etc. That if you want to say your gender, male, female, or sometimes it was there others, or sometimes they say third gender. So I hope this makes a difference. This makes a kind of a clear about the definition, Dr. Radham.
Yeah. So now we know what is gender dysphoria. Can you please tell what are the clinical features and how does it present? How can we recognize it?
Well, theoretically, if I say in my clinical experience, I have not come across a patient of this yet. But I have gathered information from the net, I would say, and talked to my colleagues who have come across one or two cases. But now, as we know, we have gone into this. You know what happens? Your mind sees what, your eye sees what your mind knows. Now we know it, probably we would come across with these kind of, people. And then, so basically what the theoretical knowledge I have, again, they say they may have changed their appearance. कपड़ों से their behavior as already like boys के या girls का different जो behavior होते हैं doing that, or their interest, again that's a simple which happens in the children. But when they go to the adolescents, then these things are reflected in a indirect ways. They may have so low self-esteem because they are not being expressed, they are not able to express themselves. Even if they are expressed, they are not being understood by the people. And if they are understood, they are again being suppressed. So somewhere a vicious cycle of, feeling low self-esteem, getting into their own, shell, being withdrawn. And of course, mental health problems are definitely going to increase with them, be it depression, anxiety, unnecessary, risk about smoking. They get rid of that distress feeling by smoking, by alcoholism, by drugs. They may have relationship difficulties, and ultimately they may end up with self-harm. Suicidal tendencies are finding, quite a lot in these patients. So, otherwise, as already told, so what we have to think is we have to catch them early. If possible, they say sign of gender dysphoria in children may present as age 4. But we do not do anything much in the children. We just keep on observing, and we can give them the parents guidance about keep on observing their behavior, not overtly discourage them, not overtly encourage them, but keep an eye on these people, because these symptoms often grow more severe as they get older, particularly once they experience the physical changes associated with the puberty. So next time when we need to make any conclusion, any decision about this, that's around the puberty. But at the same time, it is also sad that that kind of a feeling does not always persist into adulthood. So it may be 30 to 50% chances by one of the study, but still exact data is not. This is the grossly symptoms, but sometimes they may, this was the movie which I have seen was about the Danish girl. This is based on a true story of one painter. He was the first of recipient of gender affirmative surgery. So in the movie, they have down that the couple is there and they are married. And how it came out was, once they both were painter, and the wife wanted to paint a girl, and that girl was not able to come. So he poses as a girl for her. And later on, he could express that liking about being a girl, and also, took efforts to go to some other country to get that surgery. First of the surgery was okay, but he died during the second surgery, after the complication from the second surgery. So these are the things, but very beautifully explain the feeling or the expressions, in this movie. So if someone wants to know that, then please have a look on this movie as well. So few of the symptoms I have explained. So, yeah.
So what are the various treatment options available so that we can help these adolescents who have gender dysphoria?
Yeah, exactly. Availability and what to do is like, things are available, but first of all, identification. So sensitization will bring about identification, then coming to the parents to us. That is the big hurdle. But once they come, a role of psychotherapy is definitely there. And I think Dr. Arti will be taking on mental health, so not of the transgender. So not going into much of this. And secondly, I agree with Dr. Swati that validating the feeling is very, very important in the first step. So validating that feeling, that distress, and then help them to cope up with this, like find support. Now, it's easy to say, but difficult to do. Who is going to support? Parents? They are themselves, get shattered with this kind of a situation. It comes, if we come across this in our family, definitely we will be also be shattered. But yes, that's the time to speak up about all these things. And there comes, once the first hurdle of denial, of shock, and is over, yes, definitely this can be taken care by the psychologist by helping them to reduce their discomfort, how to take care of them, and how to affirm their identity and plan for future, which is very big for me to talk on this stage. But it is like psychologists are the best person. I think we can refer them for this part. There comes hormonal treatments, there comes surgical treatments. They need a legal support, definite support, societal support in jobs, work, and so we all have to work together to help them. A word about psychological intervention is, we don't do in the children. It is not advisable because it is an ever-changing gender identity. But puberty time is the one that yes, we have to decide it. And secondly, parental or family consent is definitely good to have it. And then there are various interventions. It may be fully reversible, that is delayed hormone, GnRH. I think gynecologists are very well known with that. Or it may be partially or reversible intervention like masculinizing, giving testosterone things to the one opposite sex, and feminizing hormones. Otherwise, there comes the role of irreversible surgical, which are not performed unless and until they have experienced at least 2 years in this gender role, or the psychotherapist has recommended 3, or I think I'll come in the next slide. There was 6 months of a psychological, intervention. What they do is real life experiences. Like the treatment starts is living in a desired gender role. How they do that? That their name is changed, their dressing is changed, and the hormones, if is being given them, they may be given, full-time employment in that, and legally also, okay, this name and everything is there. Once this documentation is done, that they have stayed in this life for about 2 years, or as per suggested by the psychologist, that this is the documented real life experience, then they are eligible for that affirmative surgeries. So difficult thing, but I would like to share one of the experiences by my gynecologist colleague. They have done it, and this second affirmative surgery in their hospital in Gurgaon. The thing was, she needed to sensitize each and everyone, starting from the reception till the their colleagues, how to and what to address it. They were saying कि अरे ये तो male है, because he has been documentation wise male हो गया था, but hysterectomy की जरूरत पड़ी थी. So it was a very difficult situation in the hospital also. Even after this, कि उसको मेल बुलाना है फिर भी hysterectomy हो रही है. These are the questions which were being raised by the receptionist and junior staff nurses as well. So during treatment, sensitization is definitely is must, along with all the interventions which I have described.
So how common is this gender dysphoria?
Yeah.
And what is the etiopathogenesis?
So normally what we do is, like in the topic, we keep incidences and etiopathogenesis in the beginning, because so that we know that this is our problem, this is our etiology, and we come on to the diagnosis and treatment. But here, definitely not much is known about this. And it is needed for, definitive care. But exactly again, cause is not known, still it is, under research. They may say biological, they may say environmental, so I'm not going to comment on that. It still needs to be explored. Coming on to the incidence is also not known, because it is only that the people coming for the surgery or coming for something. Well, it's like a tip of iceberg. There may be so many underlying people who have not got the resources, who have not got the, guts enough to come out. Even if they have, again, they are being suppressed. So quickly going through that, DSM-5 says it's around 0.005% and 0.014% of people assigned male at birth, and 0.002 and 0.003% of people assigned female at birth, they have gender dysphoria. In England in 2018, around 8,000 people have asked for, they were referred to adult gender dysphoria services. How many were there, still not known. And according to Beck's Medical Dictionary, it occurs in 130,000 male births and 1 in 1 lakh female births. And in European countries in 2000, early 2000, they say 1 in 12,000 male adults and 1 in 30,000 have seek out for sex reassignment surgery. So still, and another thing is, incidence is very important for them, because they need it, because this was a question again raised in IH कि उनसे पूछा कि अच्छा आप बताइए इंसिडेंस कितना है. उन्होंने कहा, आंसर वाज इंसिडेंस हमें नहीं पता है, तो क्या हम एग्जिस्ट नहीं करते हैं क्या हमें कोई जॉब में इक्वालिटी एंड ऑल दैट, हमें इतनी माइनॉरिटी अपनी प्रूव करनी पड़ेगी टू गेट ऑल दी सर्विसेज बाय द गवर्नमेंट. दैट क्वेश्चन वाज देयर. So it is again become important for the healthcare professional that where our aim is, we are not government. Our aim is that every individual health matters. So I'll quickly go through the scenario. I know there's not much time and nothing much I have to tell about this. Courtesy, it's by Dr. Latika. This case is taken, PPTs are from Dr. Latika's presentations. Again, 18-year-old, I would just quickly go through that. There was a change in her personality. She started hanging out in college canteens and other hangouts of youngsters after college. But her friends felt her change in personality, and they felt that she was becoming more lonely. That is why they were referred to adolescent pediatrician. Again, assessment already explained. Home was okay. Parents were highly educated and they want her to be educated. So post-school performance was the one when she was brought in, and education was fine. In environment, there was activities. A clue was that she enjoyed basketball and football, which is like really common. It's not that uncommon, but we take all the information, all the bits of information from homes, from heads, and then come on to the what we have to do that. There in eating and activities, it came out that she was unhappy with body and wishes that her body were more masculine. Then we continued, and once the information about sexuality was there, it was told that this was a change of gender or feeling of the opposite gender was since at the age of 4 to 5 years old. Gender expressions were she has a short haircut, long and baggy clothes, always wore the color black, and she was interested in female, never had any sexual performances in the past. Coming on she had a suicidal tendencies also. Examination clinically, she was again feature suggestive of that low self-esteem, or you can say like not in herself, not taking care of herself. She looked withdrawn, less interested in surroundings, unkempt look. I mean, all these were uneasiness with herself. So these are the heads assessment, which we do that and come out with that. Yes, there may be a possibility with that she can be having issues with her identity. Later on, the detailed assessments and all that, we do in management, which I have already discussed. So this has been a very important document, World Professional Association for Transgender Health, WPATH. This tells us the guidelines about when and where to go for definitive treatment. So I'll just quickly read about this. The first few state that it is best to wait until adolescent is 18, can consent to treatment without a parent also, and has fully experienced puberty. At the same time, it allowed to experience puberty until 10 or stage 4 or 5, and then they start GnRH analogs to halt further physical changes and perhaps hormones also to follow short thereafter at 15 or 16. And third way is start GnRH analogs at 10 and stage 2 around 12 or 13 and initiate hormones later. So these are the guidelines. More and more patients will come across, and then accordingly we'll get to know about these. So few important thing is that it's not a mental illness, but some people may develop mental health problem. That is why it has become very important for, for our another speaker to take this talk on this topic as well. And second important thing for them is their opportunities in the society once they get treatment for this, or if they do not, if they are not able to get the treatment, at least the respect, they should get it, which they are not getting at the moment, maybe or maybe not. So thank you for patient listening. Thanks a lot.
Thank you, Dr. Sunita.
I would like to ask one or two questions to Dr. Sunita, if I'm allowed.
Yeah, sure, ma'am.
Yeah, Dr. Sunita, I would like to ask, is it possible to discourage these type of the people to, change their, this thought to changing the gender? Another question, suppose it's not possible us to make them understand and they are adamant. So who's the key person where these type of the people should be referred?
Right, ma'am, as I said, it was still a theoretical knowledge for me also. But first question yours is like discourage. Discourage me, ma'am, unless and until we know the status of distress. I won't say the discourage or encourage both. We can, if they come to us at a children age, then we can say postpone, I would say the word for them. Okay, we'll see on. You try to do that, which we generally do that kind of things. But being a doctor, if a parent come to us, if we tell them discourage, तो वो तो फिर पूरी तरह से थप्पड़ मारना भी और वो सब शुरू कर देंगे. So I think that word we will not use it. But yes, we can, postpone word under the category of postpone. We will see how it grows. At the same time, ask parents to get involved in, with the other way also. So sometimes it is just a feeling only in the beginning, and it goes, it may be over by the time. That is the one thing. And second, your question, who will be the person? First of all, in my opinion, psychologist who is aware of these things, because they are the one who can take a detailed history about this. And of course,
psychologists would arrange the surgeries and everything. Who will organize?
Next, psychologist के बाद फिर जो है इनका legal procedure भी होगा. Surgery तो बाद मतलब opinion ले लिए जाएंगे with the people, but surgery and all that will be उससे पहले name change होगा, legal documentation होगा, surgery का decision मतलब एक possibility ली जाएगी, फिर सबको involvement करना पड़ेगा. That is what I think.
Yes. No, Dr.
Latika.
Yeah. Dr. Satish is doing a lot of these kind of surgeries. Like pediatric surgeons, most of the time they are involved in these kind of surgeries.
The plastic surgeons are involved, no?
Yeah.
Yes.
Yeah, they are the surgeons who are involved, and then first the decision is taken by the child, then by the parents, then of course, and then there is another issue. Sometimes the children may say that time we wanted, now we don't want it. So what is the deciding time? There are still guidelines which are not very inclusive, because last time we had presented this to our, you can say our mentor of all of us is Dr. M.K.C. Nair. He was also not able to tell us, because there are, whatever we are following is the Australian guidelines, but probably the things are still not very clear. but maximum kind of surgeries or maximum kind of these kinds are taken up by the Australian government and other people, because there they even start GnRH at the age of 12, where the child wants to get like stop the puberty. But right now in India, still we don't have a proper guideline. Only guidelines is till we have to wait till 18, whatever the Dr. Sunita was elaborating. Still there is a lot of gaps and there are a lot of loopholes. But here Dr. Alpana is doing, but main work is done by Dr. Satish.
So Dr. Alpana and Dr. Satish are doing in this one, Gangaram Hospital. That's what
they are doing other surgeries also. They are doing, especially for the children who are endocrinologically also, they are dealing with those transgender children also.
The case which I discussed was, it was being done in the W. Pratiksha, but their documentation and everything, they said it was being done there, means from Bombay. They came up with all these legal documents, etc., etc. So they came there only for the surgery, which is the things which, and now she gave me the follow-up that that guy is married, matlab jo change ho gaya sex ka, married bhi hai, and they are now going for the baby, which is like, of course, IVF or artificial donation, wo hoga, but they are, happy with that. But definitely, I think a partner, if they find it, so it's, if a supportive partner, I would say.
Supportive partner, that is what is very important. Yeah.
Thank you, Dr. Sunita. It was
Dr.
really
Swati
nice.
wants to add on quick word. Hanji, Dr. Swati.
One more film, Chandigarh Kare Ashiki, is very relevant, and it has very nicely explained how the surgeries are done and all, using the this picture form and everything, and how they go through. So that is a very good learning lesson for all of us.
Right. Thanks. Thank you.
So any more questions? Okay, thank you, Dr. Sunita, for such an enlightening talk. And thank you, Dr. Latika, for giving us a real life situation in India. So a lot need to be done even now. More and more awareness among healthcare professionals and community as a whole is required. And hope this presentation will help us all. So now moving on to the next topic of mental health of transgenders. We have Dr. Arti Anand with us. She is Senior Consultant Psychologist, Sir Ganga Ram Hospital. Dr. Arti Anand is a well-known clinical psychologist in New Delhi. She has an experience of more than 25 years in the field of mental health and has treated hundreds of patients needing psychological intervention. She is a member of Delhi Psychiatry Society. She is an expert in understanding the issues to the core and dealing with wide array of mental health issues. She also conducts training programs, workshops on cognitive behavior therapy, stress management, positive parenting, etc. for students, parents, and counselors. She is trained in individual psychotherapy and psychometric testing for children. She is a subject expert for various news channels. She has been a co-guide for DNB students in MAS, SGRH, and has been mentoring students coming for fellowship from different parts of India. So over to you, Dr. Arti.
Thank you so much, Dr. Radna. Thank you, Dr. Latika ma'am and the organization, sirs, for inviting me to the panel discussion. Just give me a few seconds. I'll just share my slide. Just a minute. Can you see it?
Yeah, it's visible. Just make it slideshow.
Wait a minute, ma'am. So I'll be starting with just a definition of what transgender means. Transgender is an umbrella term for people whose gender identity or gender expression differs from cultural and societal expectations of binary sex they were assigned at birth. A person who's a transgender may be a trans man or boy, a person assigned female at birth who identifies as a man or more masculine. Trans woman or a girl, a person assigned male at birth who identifies as a female or more feminine. Non-binary, a person who doesn't describe the gender identity exclusively as a man or a woman. I'll just give it a fast, I'll read it. Gender identity refers to a person's internal sense of being male, female, or something else. And gender expression refers to the way a person communicates gender identity to others through behavior, clothing, hairstyles, voice, or body characteristics. Now, sexual orientation is the term used in regard to those who are attracted to sexually or romantically. For example, sexual orientation includes terms such as sexual, heterosexual, gay, straight, lesbian, bisexual, asexual, queer, or questioning. So, next slide, I will discuss the mental health issues of transgenders. Challenges faced by transgenders: lack of support from friends and family. When a trans person starts to express their gender identity, they may be bullied, disrespected, and not accepted by their loved ones. Families who aren't supportive may refuse to acknowledge a person's chosen name and pronouns. They may also be unwelcoming or hostile towards their friends. Many have been threatened with or subjected to conversion therapy to cure their gender identity so that it matches the one they were assigned at birth. But conversion therapy is unethical and doesn't work. It also is damaging to a person's mental health, increasing the risk of depression, anxiety, and suicide. Here I have one case where a 19-year-old man came with his father. The first thing the father said, that I've come here, he first came, he didn't let the teenager talk to me. He came and talked to me, said he wants to change his sex, and he's a boy, and we only have one boy in our family, the only son, and he wants to change his sex, that is to become a female. And I said, how can I help you? He says, I want him to change his, come back to convert him to a normal, normal sexual identity. So I explained to them, it may not be possible, but I will talk to the patient and find out and take sessions from him. He said, okay, I've been to many psychiatrists and psychologists. All have been telling me that we will take, it's not possible. So I said, okay, let me just talk to your son. Then I had a 45 minutes to 1 hour session with him. And he told me that from the very beginning, from the age of 6 to 7 years, he was feeling different. He used to have interest in female clothing, female toys. Like he gave me examples that my other cousins would play with bat and ball, but I would like to play with my female cousins, house khelna, ya bindi lagana, and he would like to talk like them also. But he says, I could not tell anybody because it was not, matlab, I knew that something, I'm different from them. But as he became adolescent, like when he came to around 8th, 9th, 10th standard, he realized about transgenders and he read a lot of things about them. And then he thought that maybe I can be helped. But his parents and his family members and his cousins, they were not supportive. And in fact, he told me that my cousin brother had told him that if you convert into a female, he will be killed by his father and the relatives around. So this is a very, very difficult task in India, that how to help transgender community, how to help and convince parents and the family members to accept them as they are and give them time. Or maybe he told me that for last many years, he was feeling like a female, but this was the first time he was like, he told his parents. And one more thing he told me, that he said that this is also the first time that I'm telling you my story from day one to till now, because nobody was willing to tell my father directly that it may not be possible. So it's a very, very difficult task how to help, these transgender persons. And I knew that this person, father, will not come back, because he was only looking for legal, he was only looking for gender conversion, which was, excuse me, which was not conversion therapy, which the client was not ready to accept, and he was ready to change, go in for change, sex change. So this is something very important, and very important thing is that the father was an engineer, a director in a company, very highly educated, and he understood, but he could not understand his son's problem. He could understand everything, but yahan pe aake he could not, he was very sure that he cannot accept his son like this. So this is something very, very important. And this leads to depression, anxiety, and suicide. This is one of the major reasons of people going into clinical depression, anxiety disorders, and suicide. Now, second is feelings of isolation and loneliness. If a trans person is afraid of reaction of friends and family, they may not tell anyone about their gender identity and feelings. They may spend less time with others or dread family gatherings because they believe no one will support them. So they keep their feelings to themselves, and this leads again to loneliness and being isolated. Since the transgender communities lack education and employment opportunities, they are looked upon as lower class by society, resulting in exclusion. Their self-esteem and self-confidence is hit due to they're taking undesirable jobs like begging, or they're pushed into sex working, and other begging, basically mostly sex and begging. They sometimes they may escape from their house because of abusive relationships, which they don't because of which they don't have shelter or place they can call home. So they may join the kinner community. Sometimes in India we have kinner community, so they take shelter there and they start begging and doing sex work. So these are the societal and cultural discrimination going in India also. Stigmatization. They often face difficulty in property inheritance or child adoption. Because of being socially ostracized, they are compelled to take up menial jobs despite good qualifications, or forced into sex work. Victimization and hate crimes. The transgender community is not legally protected as much as any other community. And because of this, they are easily victimized for crimes that they didn't even commit. A lot of police departments are insensitive when it comes to these communities, and they do not help them or take their FIRs, and maybe they will give them aggression. They are more aggressive towards them instead of being polite or helping towards them. Fear of being themselves, a feeling of always being an outsider. This comes from the very early, as I have shown you, I have told you that a teenager who came to me, he knew from the very beginning, around 6 to 7, 8 years, he knew that there was something wrong and he was an outsider. He didn't belong to this society. So they are often forced to identify with the gender which they are not associated at workplace or in the society. Barriers to accessing healthcare. Key barriers to accessing health services reported were discrimination at healthcare facilities, lack of treatment protocols, low health literacy, and poor healthcare seeking behaviors among transgender individuals. Now, challenges at school or work. While there are some laws that offer protection in workplace or school, they are not always enough. So in India, there's nothing like this actually. People who are transgender commonly experience microaggressions such as being called by incorrect name and pronouns and challenges in using bathroom that matches their gender identity. They are bullied, they are laughed at, and they will shy, they will not open up again. Now, another form of challenge that transgender people face is cissexism. What is it? It is a form of oppression and discrimination by those who fear, disbelieve, or severely dislike people who are gender non-conforming. Some examples of cissex beliefs and behaviors are having a negative attitude towards people who are transgender, prejudice and aversion to those who are in the trans community, fearing and misunderstanding the trans community. Maybe they are going to harm us. They are, well, we will have so many prejudices that they are unworthy of living, they are unworthy of earning, they are unworthy, they have low IQs, they cannot understand. So there are many fears, or they will hurt us, fear that they will hurt us or they will rob us. So there are so many misunderstandings about them in the community. Not believing and refusing to use preferred pronouns or person's gender identity. This is a very, very big thing. Even today, as ma'am, Dr. said, that even in the hospitals, they will refuse to believe that he's, the person, the individual is trying to change his sex. They will have no respect for that person. So this is something very, very important. Why this is something so important that it affects their mental health. It can lead to so many more problems, which I will be telling in the next slide. So using offensive slurs, which we are very sure we have used or heard so many slurs, which I will not be using in the PPT. For thinners, we use so many dirty words. All of us have come across, heard these slurs. There is physical, verbal, and psychological abuse and violence against them that is being prevalent throughout. Now, depression. Research is seen in transgender. Research suggests that transgender people can have nearly 4-fold increased rise of depression, and more than 2 in 3 transgender and non-binary youth report symptoms of major depressive disorder. And transgender suicide is even higher. More than half of transgender youth considered suicide in 2021, and nearly 1 in 5 attempted suicide, according to the Trevor Project survey. Anxiety is very common. Social anxiety is possibly the most prevalent disorder found among transgenders. Recent studies say that 55% of transgender people experience high levels of anxiety as compared to 6.8 in non-transgender population. Many may feel nervous in social situations and feeling unable to interact with others, or social situations may trigger panic attack, fear and worry of being judged by others. This is very, very common. That's why most of the transgender individuals many times remain isolated, remain do not socialize, may have very few friends to confide in. Risk factors for substance use disorders are considerably higher for trans individuals, and this could be due to sexism, discrimination, violence, unemployment, sex work, and gender dysphoria, low esteem, and transgender identity. Self-esteem typically refers to how positively a person views themselves. This can reflect their self-image, accomplishments, and success. In addition to anxiety and depression, transgender youth are at increased risk of developing low self-esteem. Trans people may experience due to gender dysphoria and incongruence. Recent research says that individuals who are comfortable with their appearance and gender identity have more self-esteem. Now, this is something very important: eating disorders and transgender identity. In addition to stigma and discrimination that trans people experience, body dissatisfaction may also contribute toward disordered eating. Research indicates that many trans individuals may engage in disordered eating behaviors for gender-affirming purposes. Trans feminine individuals may engage in disordered eating to lose muscle mass and lose weight to look feminine. And trans masculine people may eliminate menstruation by restricting calorie intake. Now, there are different ways to tackle transgender mental health problems. Now, this has been already talked about. What is gender affirming? I'll just mention again very fast. Gender affirming care is a supportive form of health care designed to support and affirm an individual's gender identity. For transgender and non-binary children and adolescents, early gender affirming care is crucial to overall health and well-being, as it allows the child or adolescent to focus on social transitions and can increase their confidence while navigating the healthcare system. So, social affirmation, gender affirming care can be in these areas: social affirmation, adopting gender affirming hairstyles, clothing, name, gender pronouns, and restrooms and other facilities. And this can be used at any age or stage, and it is reversible. Puberty blockers are given using certain types of hormones to pause pubertal development. It is given during puberty and it is reversible. Hormone therapy is given in early adolescent or onwards or adult, and it is partially reversible. Gender affirming surgeries like top surgery to create male typical chest shape or enhance breasts, bottom surgery on genitals or reproductive organs are used in adulthood or case by case in adolescence, which is not reversible. Now, how family members can support, how family members, how family members and friends can help their transgender friends and transgender child or a transgender person. Proper use, support their gender identity is the first thing that the family members or their friends or the near and dear one can do it. Proper use of person's chosen name and pronouns can be one of the best ways to support people who are transgender. Ask what their pronouns are and use them. And if you hear someone else use the wrong name or gender, politely correct their error. This is the family member can help their child or an adolescent. Ask about their mental health. Many adolescents will never talk about what they are going through, what they are feeling. So, it is always very good to ask if someone is considering suicide or can potentially feeling or is feeling hopeless or anxious. So we can, the family member or a friend or a parent can talk to them. Help them get therapy. Mental health care can be invaluable in helping to manage anxiety, depression, and other mental health concerns. If you have concerns about your child's mental health, don't wait for them to ask about therapy. Don't ask. Let them know that Most people can benefit from psychotherapy and see if they are interested. And look for therapists who specialize in gender affirming care or has experience supporting people with different gender identities. Now connect them with gender affirming care. Getting respectful healthcare isn't always easy for people who are transgender. Even going to a clinic or a hospital can be a stressor. If a trans person is required to check in with their legal name or sees the wrong gender on a hospital wristband. Another very important way is understand transgender issues. People who are transgender don't always have the same rights as gender confirming individuals. For example, when trying to secure housing, public accommodations, healthcare, and using bathrooms that match their gender. Understanding and speaking out against discrimination and bias can be a way to show support for people who are transgender. Learn more about transgender issues. Now, what can be done to reduce stigma associated with dysphoria, or what changes can be made to create more inclusive environment? Recognize some of the changes that can be done is to recognize and change the norms of the society. Do not ignore, exclude, demean, or devalue another person because of their sexual preference. Pay attention to pronouns. One of the best ways to help transgender and non-conforming employees feel welcome is by using their pronouns. Many people who are transgender identify as either male or female and use he, him, his, or she, her, and hers, but others are gender non-conforming or non-binary, and they can use alternative pronouns like they, them, theirs. Always honor and protect their confidentiality. As an employer, it is important that workplace include in its non-discrimination policy wording around gender identity. Ensure leaders, managers, co-workers, and employees are trained on this policy. Make sure they know and understand the importance of confidentiality. Now, how can mental health professionals best support someone who's struggling with gender dysphoria?
Dr. Arti, Dr. Arti, sorry to disturb you. We are running out of time. So can you please be
just last,
fast?
this is the last slide. A mental health provider can help you understand and find healthy ways to explore or express your gender identity. They can provide care to help you to explore his identity and what it means to him, decide how he wishes to express his identity, both socially, how he dresses, how his hairstyle is, choice of makeup, or the name or pronoun he chooses to use, and medically, including the use of hormone medications and gender affirmation surgery. Help him plan for disclosing his affirmed gender identity to the people who are important to him. Support him as he transitions to his affirmed gender identity. Navigate relationships with friends, loved ones, and co-workers after coming out. Learn healthy ways to cope if he encounters rejection and social stigma. Manage unpleasant feelings using stress management techniques, medications, or other methods. Find helpful community resources, including support groups and other transgender healthcare providers. Thank you.
Thank you, Dr. Arti, for such elaborate talk on the mental issues faced by transgenders and sharing your real case with us.
Thank you, ma'am.
So, any questions are most welcome.
I think it was a very good talk from the Dr. Arti, and she explained each and every aspect of the transgender. But I think this is a big issue in the India, and it's difficult to handle these type of the cases. Naturally, you need a teamwork, and alone one person cannot handle these issues basically. And this is a medical legal issues. That's the most important thing, and one has to learn to cope up these type of the cases and learn to handle and manage these type of the cases. So very nicely she described all the aspects of the transgender. And I think in the future, we are going to face more and more these type of the cases. So one should learn about these cases. Thank you, Dr. Arti.
Thank you, ma'am.
Thank you, Dr. Arti, and thank you, Dr. Aradhana, for conducting, for moderating such a wonderful panel. And at the end, I would like to invite Dr. Samishta Garg, ma'am. She is a consultant. She's associate consultant at Gangaram Hospital. And ma'am, I would like to invite you to give us a vote of thanks.
Thank you, Dr. Renuka. It's a pleasure to present the vote of thanks today. So I've been listening to all the lectures very carefully, and this has actually changed my perception also towards the society, towards the individual who needs a lot of sensitization. So I would begin my vote of thanks by thanking our speakers for the first session, Dr. Latika Bhalla ma'am and Dr. Deepa Passi ma'am, for giving us an elaborate talk on sexuality and about how to handle the difficult adolescents and telling us about the red flags which we need to see in our adolescents. Our wonderful chairpersons, Dr. Gangadhar Sahu sir, Dr. Harsha Khullar ma'am, and Dr. Mala Srivastav ma'am, for giving us the key points and right message to the society. Later on, Dr. Aradhana Singh ma'am, who was a wonderful moderator, who gave us such nice case-based scenarios, and Dr. Swati Ghate ma'am, who she did exceptionally well in telling us about the romantic relationships in adolescence. Dr. Sunita Manchanda ma'am, who actually opened our eyes by giving us a new terms, which are actually new to our gynecologists, the cisgenders, the non-binary terms. Thanks a lot, ma'am. And at last but not the least, Dr. Arti Anand ma'am, she actually gave us the new norms, the new normals for our society, how to address, how to be sensitive toward these individuals. I mean, thank you is just the least I can say to them. Thanks a lot. And thank you for giving us such an elaborate talks. Thank you, everyone. Thank you. And at last, Dr. Chandra ma'am, for giving me this opportunity. I mean, my heartfelt gratitude to all of you. Thanks a lot.
Thank you.
Thank you all.
Thank you.
Good night.
Thank you, everybody.
Thank you, ma'am.
Thanks,
Bye.
Dr. Arti,
Thank
Dr.
you.
Sunita.
Thank you, ma'am.
Thank you to Dr. Latika.
And thanks, Dr. Chandra, for giving all of us an opportunity on your
I
platform.
think we all extend mutual thanks to each
This
other.
was your
For
brainchild.
enlightening us with so much of knowledge today. It was a very wonderful day.
Actually, we
Really.
learned a lot. You have been
Yes.
tackling, I mean, every day these type of the cases, but we don't come across these type of the cases. And we have learned a lot today from you.
Thanks, everyone. Good night and
Thank you.
goodbye.
Next time when we have this kind of patient here,
Good night, everybody.
Thank you, ma'am.
Thank you, Dr. Chandra. Thank you, Dr.
Thank
Renuka.
you.
Good night,
Thank
goodbye.
you. Thank you, ma'am. Good night,
Thank you,
ma'am.
Dr. Good
Thank
night.
you. Good night, ma'am.
Thank you, ma'am.